Hi there. Welcome to TIP 42, Module 8. My name is Lori Ryland. I'm a licensed psychologist, a certified advanced alcohol and drug counselor, a supervisor, and a board-certified behavior analyst. This is Module 8. This is actually Traditional Settings and Models Part 2. Part 1 was Module 7. We covered outpatient treatment components as discussed in TIP 42. In Module 8, we're going to talk about residential substance abuse treatment programs. So in this module, we will be talking about designing, implementing, evaluating, sustaining residential substance abuse treatment programs. We're going to talk about one program in particular that's outlined in TIP 42, and we're going to cover a couple of examples. So residential substance abuse treatment. The types include long-term, 12-plus months, criminal justice-based programs, halfway houses, and short-term residential programs. Now, the TIP 42 defines long-term residential as being over 12 months. When you look up long-term residential nowadays, the TIP 42 was released many years ago. But long-term residential definition can vary a little bit. But some long-term residential programs are described as being 6 months. Sometimes it can be 3 months or more. Residential treatment settings have higher rates of antisocial personality disorder in general, roughly similar rates to outpatient for major depressive disorder and generalized anxiety disorder. And these are just prevalence rates, so it does kind of make sense, that individuals who have some antisocial characteristics tend to be more prevalent in a residential setting than an outpatient setting, whereas an outpatient having rates of major depressive disorder and generalized anxiety disorder is pretty similar. In the year prior to admission, long-term residential reported highest rates of suicidal thoughts and attempts compared to outpatient, which again just picks up on this higher level of care need. Large-scale longitudinal national multi-site treatment studies have shown that participating in residential treatment shows significant improvements in drug use, crime, and employment. So a person has an increase in employment, a reduction in drug use and crime. Also positive outcomes for substance use and other maladaptive behaviors in the first year after treatment. Those who remain for 3 months have more favorable outcomes. Now, for those of you who are joining me who have just completed Module 7, the 3 months was also noted in outpatient. So individuals who have completed 3 months of treatment, either 3 months in residential or 3 months in outpatient, tend to have better outcomes than people who participate in less. So what are your considerations when you're designing a residential program? One is intake. How do people get involved in your service? How do you get paperwork completed, gather information, get insurance information, get them entered into your system? The assessment process. How do you determine what disorder the person has, or disorders as the case may be with co-occurring disorders? How do you determine what needs the person has, and how you might develop a treatment plan? How do you engage with someone? How do you engage with them and help them learn how to fully participate in their treatment? How do you develop a continuity of care, or this continuing care concept? So continuing care can mean moving from a higher level of care to a lower level of care, like for instance, going from detox and residential down to an intensive outpatient and down to an outpatient, and tapering off and becoming more involved in self-help movement. It could also be continuity of care across a level of care. So how do you help tie together treatment episodes so that you can make sure that you're participating in the person's life in an ongoing, helpful and hopeful way? And then also, finally, how do you do discharge planning? And how do you plan for the person's transition to non-treatment, to recovery in the community? So let's break each of these down and talk about them a little bit more in detail. The intake process often includes a written referral from other programs or services. So if the person is referred from outside your organization, it would have that information. Could include a diagnosis or diagnoses, history, current level of functioning, medical status, psychosocial history, and physical exam. Could also include, intake could also include this intake interview. It likely includes an intake interview conducted by a counselor, or it could be a clinical team. A lot of intakes involve more than one professional. A referral of the referral info is reviewed for accuracy, so the information that's reviewed from external sources is reviewed. The client interview, history of treatment, documentation of and identification of motivation and readiness to change, and a documentation of the willingness to accept the current placement. So if the person came in and they really want residential, but they didn't meet that level of care and they're being offered outpatient, documenting that and how the person is doing regarding their acceptance of the outpatient placement. Program review. Complete a complete description and tour of the facility. So you want to tell them, what is your residential program all about? You describe the daily operations in terms of the groups that they'll be participating in, activities that they might participate in, any responsibilities that they have. And ideally, they would be introduced to another client or clients who are enrolled in the program. Team meeting, so there could be a team meeting where the team meets with the clients to make an admission decision, whether or not this person meets the milieu, whether or not they could participate in your program. May factor involvement with criminal justice, danger to self and others, medication compliance, and motivation. There has been an increase in the availability of residential treatment for co-occurring disorders. There is still a long way to go, honestly. So years ago, getting someone into a residential facility who had a significant co-occurring issue was difficult. Nowadays there are more programs that are welcoming and open to individuals who have mental health issues. So this team meeting or this team process in the past may have had some barriers for people who have had that level of care need, but there were few providers who could handle that type of issue. So let's talk about assessment. The assessment process for individuals who have co-occurring disorder would include a substance use evaluation, age at first use, and that would include age at first use of all substances the person has used, primary drugs used, pattern treatment episodes, the mode of use, is it intravenous use? Is it, is the person taking pain medications? Are they inhaling or snorting substances? You'd document all of that, treatment episodes, and also the outcome of the treatment episodes. So if the person has participated in residential treatment 3 times in the past, you'd want to document what was their length of stay. Did they leave AMA after 2 days? Or did they complete the program and have a sustained period of recovery after that? Assessment would also include a mental health evaluation, mental status, cognitive functioning, diagnosis, medication needs, need for mental health treatment now, whether or not you'll need to incorporate that into their plan. Also, in this process, you would be identifying whether there are any communication barriers, if you need to have some interpretive resources brought in, or whether you'll have to adapt your programming to meet any speech and language or sensory deficit needs. Health and medical evaluation. Any outstanding medical, dental, or other health issues, including infectious diseases. So HIV or hepatitis, you'll want to know whether or not the person has had a health evaluation. A complete medical evaluation should occur within 30 days of entry into the program. Because it would not be uncommon for someone to not have had a physical in a while. And also an assessment of any entitlements or benefits the person currently has, including private insurance or if they have Medicaid or supplemental security income. You do want to be careful if you're helping them complete paperwork or information for entitlements, that you don't inadvertently do something that jeopardizes their eligibility. Like for instance, and this happens less now, because now it's a little bit more understood that substance use and mental health issues can both be primary diagnoses. But years ago, you had to indicate which was primary and which was secondary. And there were some situations where substance abuse treatment would state a substance abuse issue as primary. Well, mental health treatment could do that as well. And that might impact whether the person received their entitled benefits. The client status, personal strengths, goals, family, social support. Also, I wanted to make one little note about the Medicaid portion as well, and why it's so important to ensure that you're doing everything you can to help a person apply if you think that they could receive Medicaid or some other entitlement. It is often the case that that application date, that if they do get Medicaid, it may take a while, but that Medicaid would cover retroactive back to the application date at least. So that's why it's important to incorporate some of this in your initial assessment process, because it may make a difference regarding when those benefits kick in. So let's cover some engagement interventions. So in several of the modules up until now, we've talked about this concept of engagement. And here are several elements to engagement, 7 in total. The first element is client assistance counseling. So the description of it is client responsibility, coaching, senior peer provides assistance. So you're essentially coaching the person in how to take responsibility. Medication, monitor for adherence, side effects, and effectiveness. Active outreach and continuous orientation. So you're building a relationship with your clients, you're enhancing compliance, and you're engendering acceptance through multiple staff contacts. You could have a token economy to help improve engagement. So it could be, there are many ways to do a token economy, so we won't talk too much about that today, but contingency management is an evidence-based practice that can be highly beneficial in many programs. But one example is you could have points for positive behavior that are redeemable for tangible rewards. So the person can save up points for phone cards and toiletries, or that you can also use a lottery system or something like that for a token economy. So the person could enter into certain lotteries for larger prizes. Pioneers, creating a positive peer culture. Now this is a seedling group of selected residents to transmit peer mutual self-help culture and encourage new clients to make use of the program. So this is peers helping peers, peers helping the clients that are coming into your services to connect and fully benefit from your program. Client action plan, specify, monitor, and document client short-term goals by attaining smaller objectives. So the person comes in with some goals, and both short-term and long-term, and you assist them by breaking them up into what are the steps that are required in order for them to meet their goals. And the last one is preparation for housing. Available treatment and housing options are explored. You might talk about work readiness and household management.